So I get to ask a question. So I wanted to say that this was mentioned at the Eastern Town Hall that now there is a CLIA code for PFAS testing, blood testing, and a law in New Hampshire for insurance to cover PFAS testing. And we're now working on making sure that those tests are high quality. We know that insurance coverage would be a game changer, as would programs like was mentioned in the previous panel for lead to be applied to PFAS. So I think we're on the road, hopefully, to getting better access to PFAS testing, and the Academy study would, really contribute to that and have a lot of credibility. So I hope that you could all, I know Sandy, you touched on this in your talk, to share some feedback, because this is one of the tasks that the Academies has been tasked with on current PFAS testing and health guidance. What do you want your doctor to know and have access to? What do you think they should be testing for and why?
Are you asking all of us, or what?
Yeah.
I'll start. What the heck? Yeah, I do think there needs to be blood testing, especially when we have populations that we know are contaminated. So, in Michigan, if there's industrial waste, if there's an airport nearby, if there's a military base, and if there's been a large fire, those are 4 areas that we can pretty much guarantee groundwater's probably been contaminated. And then there's probably other areas as well. But I think people need that because it is just one more piece of the puzzle that they can then use with their physician to help manage medical issues. And not having to pay for it out of pocket is huge. It's very expensive and it's very hard to get. I had to take a half a day off to FedEx it and store it and do all sorts of craziness.
I agree with Sandy. It was a fight to get my blood tested, and I kept getting told probably many of the same things you did, and it was $1,000. And the doctor was arguing with me, well, your insurance isn't going to cover it. And by that time, I was like, I don't care. If I have to pay the whole amount, I will. And insurance did cover 90% of it, so that was good. But, part of the thing, and I know it's going toward, everyone's measuring all these individual PFAS. And to me, that's a pet peeve of mine. And yes, I'm not a medical person, but I'm definitely a fan of total fluorine, which gives you a truer picture. And let's look at how this is all working together and impacting. And actually there's some things being worked out for testing total fluorine. But this little game of 4 PFAS and 6 and 12, I had tested water in Lake Michigan, and I had the University of Wisconsin testing it. It was $600 a test. And I got back 6 PFAS. And I'm like, well, I won't make that mistake again.
Yeah, I completely agree that, the current scope of what can be tested, it doesn't capture, for example, like fluoropolymers, like, what would be in Teflon or, they're all saying PFOS free now, but that just means they're using some other kind of fluoropolymer to make that surface. Beyond that, I know in the last panel, there was a question about programs that were used for other contaminants. And I think Minnesota, we have a blood lead level testing that's required for, I believe, all children in Minnesota when they're of a certain age. And, with the amount of contamination that we're seeing in Michigan, wherever they've tested for it, they've found it. And when you look at a map of PFAS contamination in Michigan, it's everywhere. We haven't even done that level of testing in Minnesota, but wherever we're finding, or wherever we're looking for it, we're finding it. So if we can just do an initial test of all children, I think that, that could be really impactful to identifying potential problems in the future.
Yeah, those maps are great for seeing which states are testing.
Oh my gosh.
It tells you. And just a side note back about the CLIA testing is we did find one lab, the insurance covered lab that was being used was only testing for the linear and not the branched. And typically both the linear and branched are tested for. So that would mean people are getting back concentrations that were much lower than they probably would be with standard testing. So just worth a heads up to everyone to look out for that. So with that, I'm just gonna pass it over to the committee, which I'm sure has lots of questions for you. Looking for hands, or just pop in video if you have a question for our panelists today.
So I have a question for Mrs. Winstelt. First of all, and thank all of you for your moving testimony today. It's all very helpful. You shared that you have it sounded like a pretty good relationship with your physician and with the conversation. I'm wondering if your physician shared with you after reading the document from ATSDR, what would help him as a physician to be able to work with his patients? Have you had conversations along those lines?
Yeah, we talked about the frustration is, I think, because this is such a huge class of chemicals, and the C8 study is kind of the gold standard that everybody looks to with that. But that was only the PFOS and PFOA. So trying to extrapolate from that when you bring them in a blood test of the rest of it is rather tricky. And I think the guidance from the ATSDR is very hesitant at saying that you can really find anything with anything. And so it made it quite vague, I think, was some of the frustration. But I mean, at least we had something, and I will give credit to that. The C8 study was something that we could go from and use.
All right, thank you.
Kevin, I think you're up next.
Thanks. Yeah, I just had a question following up on Tom's comment about I think he briefly said the East Metro area had a biomonitoring program. And I was just curious to follow up on that. If you thought, Tom, that there are things that we could learn from that, if you thought there were strengths and weaknesses associated with that effort.
Well, I think the strength is that they keep testing the same group of people over several years and continue to go back to it, especially right after any kind of intervention has taken place. So I think you do learn a lot, as I mentioned. After a water treatment plant was installed in Oakdale, one of the contaminated communities, they found a significant drop-off in blood levels in that region or in that municipality. Similarly, they then tested new residents that had come into Oakdale since the water treatment plant had been installed. New, I think it's a GAC filter that they have on that. And those levels of new residents coming in tested at about the same as the general US population. So it was a pretty clear, that was the main route of exposure to those residents. Beyond that, I think also that those testing led to a later study that made a pretty clear correlation between birth weights in Oakdale before the water treatment system and after the water treatment system. And of course, those birth weights were much more normal after that water was being treated for PFAS. So yeah, I think there's a lot of strengths of the program. The only thing I'd say that is a weakness is that we can't provide it, more broadly.
Thanks, Tom.
Thanks. I think Alex has a question.
Yeah, first of all, I'd like to echo what everyone else has said in terms of thanking the panelists. This has been really helpful in terms of helping me understand what the issues are related to testing. And I guess my question is probably best directed to Sandy. So I'm thinking about the purposes of testing. So you could test from this perspective of, I guess you would call it environmental justice, right? Trying to figure out who's been contaminated. You can also test to inform things like future cancer risk, or whether or not individuals need to get surveillance for cancer. And I kind of hear, as I hear the story, sort of testing for both those things. And I was hoping if you, from your perspective, could help me sort of disentangle this and what you really think the benefits of testing are.
You know, my first thought is, if you're going to do medical testing, you would want it to be relevant to the patient that's getting tested. So I think not just surveillance for cancers, but all these other diseases that we're finding run in correlation with this, both so that they can be on the lookout for those and treat those, but also take preventative measures. If I'm going to be at higher risk for cholesterol with this, I may cut out the pizza, you know. As far as the justice piece or creating your case, as it were, I think that's going to be up to the individual. I am less, I understand the value in that, but I am less concerned about that as I am being able to give information to physicians so physicians can work with their patients at really taking the necessary actions. The other part of that is there's people that may be afraid that they have been contaminated, and blood testing may also provide some sense of relief when they find that, in fact, maybe they were not as contaminated as what they had thought. This PFAS, especially when you're talking groundwater issues, is a real interesting character, how it ebbs and flows and can change greatly over time. So those are just my thoughts.
And can I just build on that a little bit more too? Then would you argue that testing ought to be just a blanket thing that would just happen kind of the same way that we test 1 and 2 year olds for lead without much of a conversation? Or would you envision some sort of informed conversation with an informed clinician, right, who understands what the issues are, and then based on the individual's preference, then test?
I think I would like to see an informed conversation that people make that opt into it, basically. You know, one of my concerns is my primary diagnosis on my medical record now is extreme exposure to environmental toxin. And I always wonder, is that going to become a pre-existing condition in some way? So I think it does have to be a conversation with your doctor that people choose to have. I think doctors, it will help. I think other panelists had talked about the idea of adding environmental contaminants to a questionnaire you do, just like you do a Beck depression scale, just like you look at history of drug and alcohol use, family history of different diseases. I think exposure to environmental toxins would be important to have on there too.
Okay, great. Thank you very much.
Thank you.
Thanks. Are there any other questions for our panelists? Well, if not, oh, Melissa, Dr. Gonzalez.
Yes, I have one more question. And again, I want to thank everybody for their time and very informative information. I really appreciate it. Vicki, you mentioned that you got a request from a military firefighters chain of command for information on what to give to the individual who had been tested. Could you tell us a little bit more about that information, and also have you heard about how these how this information has any information come back to you about how this was approached with the physician or used by physicians?
That was about the extent of the conversation that I had, because first off, it was the first time someone had asked me that, so it kind of threw me off. And you know, I was stressing I'm not a medical person, but this is what I know. And then I sent him. I work with Laura Ola of C. Schwab, and she had done a very good factual PFAS blood fact sheet. So I sent that to him, which gave information such as, you know, the doctors and questions to ask, and just kind of broadened the amount of information, because as we all know in this group, it's just overwhelming how many levels and how many facets of this there are. You know, firefighters, they want quick information. They want to know what to do, you know, like right now, okay, this is the problem, here's the solution. And that's not going to work with this, for instance. I know he did talk to the guy. I never heard back from him as far as that is concerned. So that's about the extent of what, you know, I had. I know he talked to one of our other committee members who's a military firefighter. He followed up with him too.
Thank you. Can you tell me again who wrote the PFAS?
The fact
Blood
sheet, the
fact
blood
sheet.
fact sheet. Laura Olah, Olah. She is with C. Schwab, SCHAWAB. She talked in the earlier session. And they have a wonderful website, and she's really helped us out because she made a firefighter section for us.
Thank you.
Okay. Any other questions? I think we've got a few minutes. Time for another question or two if anyone has any.
Quick question for you, Courtney. You mentioned that there's now a CLIA code for PFAS testing, and you mentioned one of the states, and I kind of missed which state it was and what they had, what you had said about the state requiring.
It was New Hampshire. I learned about it at the Eastern Town Hall a few weeks ago.
Yes.
That New Hampshire has some legislation that apparently requires insurance to cover PFAS blood testing.
That's what I thought you would
Be
say.
a code for it. And so when we kind of went to that site and looked at what they were offering, it said that they were reporting only the linear PFOA and PFOS, which is unusual. So we've sort of been looking into that to see, you know, if they can fix it. But I guess that was sort of an unexpected thing. You know, you think you work in this world and you know how to do, you know, how the testing is done. And then it just never occurred to me that people would be getting blood results back that were, you know, not really comparable to the methods that are used in the way that they're reported back for NHANES and other, you know, communities that have had testing. So anything you compare those results to wouldn't really be a fair comparison.
Thank you.
Okay, well, thank you, everyone. Appreciate you sharing your stories today, and hand it back to Ed.
Thanks, Dr. Cagnan. I want to thank you, a great job moderating. And I especially want to thank the folks who testified and shared their stories, their expertise, and their guidance to help this committee continue on its journey in doing this work. These are important sessions. They add information, and I think, as Dr. Wyatt said, a personal touch, a narrative that I think is really key to us doing our work and making good decisions moving forward. What I would like to do at this point is take a 10-minute break. It's about 14 minutes after the hour, so we're about 4 minutes behind, which is pretty good. So we'll convene, let's say reconvene at 25 minutes after the hour with our third panel. And again, I appreciate all your time. I would really encourage folks to get up. We've sat for a long time and listened to a lot of information. And so a little bit of physical stretching and a little walk to somewhere, even for a bio break, I think is really important. So I'll see you all in about 10 minutes.